So, welcome back, everybody. We will continue now with the presentations of the studies driven by ECRAID, and Mark has explained what that means. We will have 7 presentations of about each time 10 minutes, which leaves us roughly 5 minutes for discussion. I'd just like to mention to the speakers that there is a very short delay of 1 to 2 seconds if you ask for the next slide. There's nothing we can do about. So just be aware that this might take 1 to 2 seconds before you get the next slide when you ask for the next slide. So it's my really great pleasure to welcome and invite a dear colleague and friend, Chris Butler of the University of Oxford, who will talk about the PRUDENCE trial. Chris.
Thank you very much, Herman, and thank you so much, colleagues, for the opportunity to present what is a very exciting trial and firmly affiliated and embedded within the developments towards ECRAID as a comprehensive infrastructure for infections-related research across the spectrum of care. And this trial arises from the ValueDx consortium, and it's around point-of-care testing for infections in primary care to enhance the quality of antibiotic prescribing for community-acquired respiratory tract infections. And it's a joint effort, of course, with many valued colleagues, some of whom are on this call. Next slide. Just to quickly mention the context, why is it important? Why do we want to try and get a better match between a prescription of an antibiotic and somebody who's likely to benefit and keep the antibiotics away from those who aren't? Well, most antibiotics are prescribed in primary care, and we have a lot of evidence now that outpatient use of antibiotics in primary care is strongly associated with resistance, both in primary care patients and when they get into hospital, and outcomes are generally worse if they have resistant organisms causing their infections. And we can see that even in primary care, where most people will get better, but it'll take almost twice as long sometimes if they've got a resistant organism, and they're going to consume more antibiotics, which stands to reason. If the bug's resistant, you're going to have treated again and again. And we've shown some evidence that those general practices that prescribe fewer antibiotics over time will start submitting urinary samples that have resistant organisms less often. Next slide. So one thing that sorry, it's just taking its time. So the concept is that we need to use our antibiotics far more wisely, and the point of care tests have got huge potential in guiding quality antibiotic prescribing decisions. Next slide. So to get back to Mark's point about doing cool science, we didn't want to just do Me Too studies here. We wanted to actually answer a question. Do these point of care tests make a real difference to patients? And we know that there are numerous studies around analytical performance of tests. How does it compare if you measure something in the lab using the new test with the existing big machine? Many studies like that. Some studies of clinical performance. What happens? Do you get a good answer if clinicians or people in the field do the test? And then does it make a difference to patients, the clinical effectiveness? Does it make a bigger difference than other strategies, other tests, or care without tests? Very rarely do we see cost effectiveness studies and broader impact studies. Next slide. And the next slide will show you just really the frequency or the number of studies done in these different domains. And you can see studies of clinical effectiveness, comparative effectiveness, cost effectiveness, and broader impact are very rare in this field. Next slide. So in Prudence, we're looking for anybody to recruit, an individually randomized study aged 1 year and above who has an acute respiratory infection and who the responsible clinician is considering or has already decided to prescribe an antibiotic. And obviously many exclusions, for example, immediate hospitalization or non-infective presumptive diagnosis. And we're comparing management with a community-acquired acute respiratory infection diagnostic with management without that. And that's usual care. And our outcomes will be antibiotic prescribing and equivalence in terms of recovery. We don't want to reduce antibiotics at the expense to patients. Slide, please. So we'll follow our patients for 28 days, a wide variety of outcomes. But the main issue is to see whether these point-of-care tests reduce the duration of illness and antibiotic use, and importantly, whether this is benefiting patients and is cost effective. Next slide. I won't go into the technical side of the cool science, but we're aiming for a meaningful reduction in antibiotic use without causing patients to be sicker for more than a day. And we're anticipating about 1,250 patients per trial arm in a 3-arm trial arm comparison. And we have the capacity in this platform trial design, if we get answers for the current point of care tests, to introduce more. Next slide, please. These are the point of care tests. We'll have usual care. We'll have an arm with the Affinion C-reactive protein test from Abbott, and an arm with the Veritor from Becton Dickinson that can measure flu and group A streptococcus. Next slide, please. We've updated our algorithm to take into account the COVID pandemic, and I won't go into details there, but for those who haven't had a COVID test, if the clinician wishes to do it, that will be available through the BD platform. Next slide. We've already recruited 10 countries from our primary care point prevalence audit survey that was done prior to this. We also include some long-term care facilities from 5 countries. Next slide. We'll also do a process evaluation. I won't go into the details here, but we'll do qualitative interviews with clinicians and patients, looking for barriers and opportunities for effective uptake of point-of-care tests in primary care, and for sustainability of these interventions. Next slide. So in summary, we've got our protocol finalized, we've developed our algorithm, sponsorship is achieved, and we're in the process now of training the networks that will be implementing this, and we'll be doing that later this week. So with a fair wind behind us, we're hoping to have our first patient in October. Next slide, and I think that's it. So thank you very much for the opportunity to present this, just to give you a little flavor of how a trial like ValueDx will be flowing into the broader development of Ecraid. Thank you.
Thank you very much, Chris. Indeed, a very exciting trial. What do you think will be the biggest challenge of this trial?
Biggest challenge, I think, is to implement a trial in primary care at a time when they are seeing less patients face to face, where their busyness has increased exponentially. so that really space and time for research is reduced. But I think we can overcome these. We have enthusiastic networks who've proven their capacity to deliver research. But I think the main thing is adapting the testing procedures to the COVID world, and also the capacity of primary care to implement research at the present time.
Okay. Thanks, Chris. Are there any questions for Chris? Any comments or questions? Marion Koopmans, in University Medical Center, Erasmus Medical Center, Rotterdam. Marion?
Yes. Hi. Thank you, Chris. So I'm wondering, because we are seeing, that's also a question maybe for Herman, we are seeing a big change in the provision of laboratory testing because of COVID. So there's been because of the massive testing, there's a lot of new players that have moved into the, what you would say, diagnostic market, or players that were there but now have really shifted in position. Does that, in your view, change how we interact also as LabNet with some of these players?
Chris, you want to start about impact of the COVID-19 pandemic on the trial and diagnostics?
In the sort of Value DX project, we anticipate that a lot of people might be not seen face to face, and therefore the opportunity for doing diagnostics is diminished, because a lot of this will be through video or telephone consultation. But the way we can do this is that people can still come to a practice or to a point where they can do the tests, and then discussions can be had around that. However, face-to-face consultations are on the increase again, and so opportunity for testing is going back up. So I think that although we've been through a dramatically a reduced period for diagnostic testing, this is changing, and I think, you know, before we were managing, for example, urinary tract infection on the telephone, but we can still build in dropping off a sample for testing there and bring people in now for respiratory infections. I think a lot of people were tested in the community away from primary care clinics for COVID. And if they'd had that test, they often didn't see the need to come down. And that kind of central testing facility might be changing, with more of it coming into primary care clinics as well.
Yeah, I agree with Chris. And in fact, I mean, these are exciting times now, Marion, because COVID-19 has demonstrated the importance of diagnostic testing and of microbiology. And I think everybody knows now what PCR is, whereas before the COVID-19 pandemic, nobody would know what it means, but now everybody knows what PCR is. So yeah, it certainly provides a huge boost to the diagnostic field. But yeah, there are indeed new players now, particularly new players developing home tests, because many countries have introduced testing through pharmacists or self-testing. And so that's going to be very interesting to see what impact it may have on future testing through during the winter season with other respiratory viruses, and whether these home tests will indeed have a benefit in our algorithms, or will have a place in these algorithms in patients with acute respiratory tract infections. So I don't think we'll go back to the pre-COVID-19 pandemic era. I think the era of diagnostics has changed, or will change after the pandemic. So I think it's going to be very exciting times. Would you agree, Marion?
I agree. It's also shifting. So if you look at the pre-pandemic model for rapid deployment of emerging disease diagnostics, that was more or less established through existing networks. But right now that is different in the sense that I think some of these big international commercial labs may be setting those standards, and I'm not sure how connected they are. So I think it's worth considering or discussing how to work with that.
Yeah, if I could chip in there quickly, Herman, I think sure. the slide I showed about different types of evaluation of point of care tests is critical, because a lot of proposals come from a variety of quarters, including industry, saying we've got a test that is 100% accurate. But what they've done perhaps is to spike a sample in a lab and compare their test with a machine. That doesn't tell you how that test performs in the real world. So evaluations which constitute clinical effectiveness and cost effectiveness done by independent organizations such as Ecraid will be absolutely critical to deciding which tests should be deployed and commissioned.
Good. Question from Jan Verbaak, who's done a lot of work on this as well. Jan?
Yes, hi Herman, thank you. And Chris, thank you for the presentation. Very, very promising project. My question is rather on the effectiveness. So I assume the sample size calculations were done before COVID with reduction in antibiotic prescribing rate. What is your take on the impact of COVID on the choice of antibiotic? And as in the past, GPs used the phrase, well, it's just a viral infection, it's nothing to worry about. Now with COVID, it's not necessarily the case. So how would this impact their prescribing behavior?
Yeah.
Chris?
Yes, thank you for your question, Jan. And you might have noticed that the two diagrams that I showed about the phases of diagnostics research came from an important paper authored by Jan himself. So it's very appropriate that he is asking that question right now. Yeah, so it's difficult to know what the impact on the pandemic will have or is having on antibiotic prescribing, given that we've had lockdowns, we've had fewer viruses circulating, and the prevalence of different organisms is changing rapidly and is unknown. So what we are aware of is that I think antibiotic prescribing came down in most settings during the pandemic, but then far fewer people were consulting in primary care with respiratory infections. And I think that is changing now. We're seeing a lot more RSV and other organisms, and then that is going to be triggering or is triggering more COPD exacerbations and so on. So the precision of our sample size calculation is less certain than what we had before the pandemic. And the target patient is one for whom the clinician has decided to prescribe an antibiotic, or is highly considering that. And you know how often that will happen over the coming winter, we don't know. So it is a bit of a suck it and see approach that we'll have to go with.
Yeah. Okay, I think we need to close this discussion. So once again, many thanks, Chris, and good luck with the trial, of course. All right, so we move on to the, let's say, sister or brother project in ValideX called Adequate, and Adequate will be presented by Cristina Prat of the University Medical Center Utrecht. Cristina.
Okay, so hello, thank you very much also for the invitation to present the Adequate project. That Adequate stands for Advanced Diagnostics for Enhanced Quality of Antibiotic Prescription in Respiratory Tract Infections in Emergency Rooms. So yeah, the sister or brother of the PRUDENCE trial, but then in emergency rooms. And well, in the first slide, it was mentioned the team that is taking place in this Adequate so far, and it's from the UMC Utrecht, these persons, and from Penta Network, the pediatric part, and the company. So the ValideX is an innovative medicine initiative project. The company involved is Biobank. So now, yes, next slide. So the background, I will repeat a little bit, but I would like to mention some special things. So that we all know that the community-acquired acute respiratory tract infections are a leading cause of morbidity and mortality. And it's a common reason for consulting in emergency departments. And this, compared to PRUDENCE, what we know, it is that the setting, the consultations are very different among countries. While in some countries in Europe, it is very focused on primary care and only reaches the emergency rooms, a subset of these patients, the ones that really need hospitalization. In other settings, this is not exactly the same. And of course, the impact of diagnostics in these different settings, in these different geographical areas, may be different. And we know that just like in primary care, in the emergency rooms, these community-acquired respiratory tract infections are a frequent cause of inadequate antibiotic prescription in some cases. And it's a kind of suboptimal. And at the same time, it was just mentioned that the value of diagnostics, and before the COVID, we knew that there were highly sensitive molecular assays that were reaching the hospitals, not so much the primary care, that increased the detection of the respiratory pathogens. And this was making a big change, and now has even been increased by the new partners coming into consideration. But the real impact in the clinical decision making was not properly evaluated so far. So next slide, please. So the rationale for the adequate study is because we all agree that the clinical management of these infections is often suboptimal, and there are different reasons for that. It can be that the correctness of the etiologic diagnosis, because we must not forget that to detect a potential pathogen is not always the same than that is the etiological agent on a respiratory tract infection, because we have enough commensal flora, or we can have even with pathogens that are considered primary, it can be that is a previous detection of a nucleic acid or so. And the choice and dosing on the duration of the treatment is also suboptimal. There are many discussions whether to treat, how long, when to treat first, and then how long and when to de-escalate. So then there is a need to assess the real impact of this rapid microbiological testing that we are facing now in the clinical decisions regarding the antimicrobial prescription, that means yes or not and what, and the hospitalization or not, because we are talking in this case about the emergency rooms. Next, please. And now I go to the template of ValueDX. So in this context, we decided within the work package 4 that this was the clinical trials, that we will do the A in the primary care, and that was the just presented PRUDENCE, and the B that will be in the emergency rooms. And later on, we also decided to split the protocol in two parts, the adult and the pediatric protocol, that this is the clinicaltrial.gov numbers, that the protocol is essentially the same but adapted to the setting, because it's quite different except in the extreme parts of life, but the adults or the pediatric, it's a little bit different, and the analysis will be all together. And this was designed, you can go to next if there is delay, as an individually randomized trial. So it also has co-primary objectives that are to assess the impact of the rapid syndromic testing, and I will explain just after what we mean with rapid syndromic testing, in patients presenting with community-acquired acute respiratory tract infections in the emergency room, the impact in the days in hospital within 14 days, the days with antibiotic therapy within 14 days, and the occurrence of an adverse outcome within 30 days. And this was translated into endpoints as the days alive out of the hospital and the days of therapy, both within 14 days. These are the superiority endpoints. And as a non-inferiority safety endpoint, we considered for the patients that are initially non-admitted to the hospital, any admission or death within 30 days, and for the ones that were hospitalized, any readmission or ICU admission, or of course, death within 30 days. And we did different time points because the decision in the emergency room is fast enough, whether to treat with antibiotics, yes or not, or to hospitalize, yes or not. But the the consequences of that decision may come a little bit later, whether there is a readmission or where it failed in the treatment. Next, please. And then there is also a set of secondary objectives, and here we are going very deeply to the health economic analysis that was just mentioned, because of course the rapid syndromic testing is expensive and it's not available in every site. So we need to really demonstrate what is the real impact in terms of economy also. So then there is an assessment on the healthcare utilization, but then also on the quality of life. Then we also want to quantify the additional diagnostic yield and the sensitivity of this rapid syndromic testing, because of course now we are testing much more, but we are testing one pathogen or two or three, but this rapid syndromic test has more pathogens. Some of them until now it was not available many methods that can do it so rapidly, and this has pros and cons, because of course you have more diagnosis, but then you need more careful interpretation of the results also. And then also to quantify on the antimicrobial de-escalation, because the primary it's more on the yes or no, but in this case we also mean if we reduce the number of antibiotics or the spectrum, and to quantify the detection of antibiotic resistance, which it's also an ecological measurement, and to assess the impact on measures like the bed management or the isolation measures, that this was written before the pandemic and we were more thinking about the flu epidemics or about the multi-drug resistant bacteria, but now we also had COVID, of course. Next. And then the diagnostic intervention that is in the adequate study, after different companies are participating in the ValueDX consortium for the emergency rooms, it was decided the BioFire film array from bioMérieux that has two panels, the Pneumonia Panel and the Respiratory Panel 2.1. The first one, the Pneumonia Panel, of course, aims for the syndromic diagnosis of the lower respiratory tract infection, mostly pneumonia, but I already mentioned that we don't include pneumonia in the inclusion criteria, and I will go back to it for a moment later on. And this is performed in lower respiratory tract samples and includes the detection of bacteria semi-quantitatively, including antimicrobial resistance genes, so for the detection of multi-drug resistance. And then, as a typical pneumonia bacteria, it includes Legionella, Chlamydophila, and Mycoplasma, and a set of respiratory viruses. And on the other hand, the BioFire Respiratory Panel 2.1, it is performed in nasopharyngeal swab. That also, before the pandemic, there were not so many nasopharyngeal swabs performed except during the flu pandemic, but now everybody gets several. And this includes respiratory viruses. In this case, it was included during the preparation of the study, it was included the target of SARS-CoV-2. And then as a typical bacterial pathogens, because we are now focusing on other clinical syndromes, is Bordetella, Chlamydophila, and Mycoplasma. Next. And then these are an overview of the study procedures that I just want to mention, that there is a part of eligibility. And for this, I didn't include, to make it shorter, a slide of the inclusion and exclusion criteria. But the more important inclusion criteria, because we are talking about an hospital setting, is not only the signs and symptoms of a respiratory tract infection, but that the managing team has a reasonable doubt whether to treat or not, or whether to hospitalize or not, because this is what we are assessing in this study, and whether it thinks that to have a diagnostic test may aid in that decision. Because if we have very clear that no antibiotics or no hospitalization, or the other way around, that patient is not eligible. And of course, this excludes, for example, very clear lobar pneumonia. And then the assessments are at these time points to ensure the outcome measures that are the days alive out of the hospital and the days on therapy and the adverse outcome. And of course, this may depend how we do it. If the patient is hospitalized, is the follow-up during the hospital course and then after discharge until day 30. And if the patient is not hospitalized, then there is a questionnaire at day 15 and day 30. And of course, for safety, any readmission during or admission that was not previously planned during that time period. There is also extension study that will assess mostly these same parameters, but also the health, economic, and the quality of life at 3 months and 6 months. And to adjust to the time, my final slide is next. This is the study flow chart that is more or less what I explained, and we can go back if needed. Next. This is the current status that we have an adult and a pediatric protocol, and the sample size calculation is this one mentioned here. And yes, also it was made before the pandemic, but we still think it can adjust. The respiratory samples are the two types, the lower respiratory tract and the upper respiratory tract for adults, but for pediatric, we will only use the nasopharyngeal swab, so then only the panel. And of course, the differences in the diagnostic intervention. And there is a sub-study in the adult for the extended follow-up and a sub-study for the pediatric regarding a microbiology study that will be some biobanking. And at this moment, there are 7 sites selected in the adult protocol and 6 in the pediatric. And we have already 4 sites activated in the adult and 2 in the pediatric, and recruitment has started just this summer. The summer is not the ideal time for acute respiratory tract infections, but given the different process in hospital care compared to primary care, we decided to start up sequentially, and we are this far. So thank you very much.
Okay, thank you very much, Cristina. Another exciting study of ValidateX, but also challenging. I don't think we have much time for questions. I see a hand of Jan Verbaak. Jan, is that an old hand or is it a new one? Maybe it's an old one. No, can't hear him. Very short question, maybe short answer. The same question as asked Chris. Cristina, what is the biggest challenge of this trial?
Well, of course, the pandemic by itself, because of course there was a total change in the circulation of pathogens, and now it was COVID-19 or nothing, a little bit, but it also makes some progress that everybody is much more aware of the value of diagnostics, and we aim to explore very carefully what is coming back slowly and what is the changing scenario. But we think it will go on. Yeah.
Okay, I'm sure it will, Cristina. Okay, good. I think Maria, I see your hand, but unfortunately, I think we need to move on. So maybe why don't you send an email to Cristina, perhaps, if you have a question, Marie. But I really suggest that we move on. So once again, thank you very much, Cristina, and good luck with the trial. Huh? So then we move on to 2 studies were born in Prepare and then continued in Recover, MERMAIDS-ARI 1.0 and MERMAIDS-ARI 2.0. And James Lee of the University of Oxford will present MERMAIDS-ARI 1.0. James.
Thanks, Herman. And first of all, thank you for inviting me to talk about MERMAIDS-ARI. I'm representing a whole bunch of people that have worked on this study over the past, I think it must be 6 or 7 years now. So yeah, it's difficult to mention everybody, but pretty much nearly most people on this meeting have worked on it in some part. So what is MERMAID? So MERMAID actually comprised of 3 studies originally, starting in Prepare. So MERMAIDS is the multi-center European study of major infectious disease syndromes. And those 3 studies were for ARI, so acute respiratory infection, looking at determinants of severity of acute respiratory infection in primary care and secondary care. We had the arbovirus study, which recruited patients in Eastern Europe, looking at the burden and clinical management and impact of arbovirus illness in this region. And then we also had the pediatric study, which was run by Mike Sharland and his team out of St. George's, looking at etiology of sepsis-like syndrome and etiology of ARI in infants and pediatrics. Next slide, please. So we had we have a network of, have we missed a slide there? Is this the next slide? I can't see where we are. It's moving around. Okay. That slide, thank you. So MERMAIDS-ARI, this one is really forming the basis for the perpetual observational study in Ecraid. So MERMAIDS-ARI 1 was looking at host and pathogen-related determinant severity in acute respiratory infections. And really, we were looking at why some people become more unwell than others. What was it about their host gene expression profile that makes them go on to develop severe disease? And we were able to actually compare between mild and severe groups from hospital and GP practices. And we were stratifying by different pathogens and comorbidity. And Peter Horby and Menno de Jong, who are the principal investigators for the study, assure me that this is the largest ever study of this type done in the world, where we stratify by different pathogens and comorbidity. And we do this by taking sampling at points day 0, day 2, for hospitalized patients when they're discharged, and then a convalescent sample taken on day 28. Next slide, please. And overall, we have a network of 70 sites over the past sort of 6 or 7 years, and we've recruited in 7 countries. And I did have an animation here, so I'm not sure if it works. Do we have an animation that we can play here? Sorry, I don't have control.
Yeah, I emailed you yesterday about it, but the image, unfortunately, due to security, doesn't work in the presentation.
Oh, that's a shame. That was my pride and joy, that animation. Oh no.
Oh, no.
Okay, but what it was an animation showing over time and all of the sites that we recruited over the past few years. And what that did show is we had good distribution of sites throughout Europe. But what happened is when the COVID pandemic came, it illuminated up the UK, where we were able to recruit all of these sites in the UK. And that was really due to getting the urgent public health status from the NIHR in the UK. And I'll talk about that in a second, in a few slides. Next slide, please. So this is how the timeline has worked for recruitment for MERMAIDS-ARI. So it started back in 2004. Up until 2019. So we had a good solid 4 recruiting seasons. So we recruited through the winter period. Then we had that gap. And then we got the recover funding to recruit for when the COVID pandemic hit. And then obviously, as we're going into 2022, we've got Ecraid to continue perpetual observational study for ARI. But what I would like to highlight here is that gap in 2019 to 2020. So this had a significant impact on the engagement of the study, which I think Ecraid is going to be able to resolve that for these perpetual observational type studies. Next slide, please. So what we did with MERMAIDS-ARI was we were able to pivot the study for COVID-19. So within Prepare, we have the Prepare outbreak modes, which is set up for different stages of pandemic response. So back in January 2020, we kind of knew what was happening with the COVID pandemic, though it wasn't until March when the WHO declared a fake that we actually were able to respond in Prepare and get additional funding to reactivate the clinical study, MERMAIDS-ARI. Next slide, please. So importantly, for MERMAIDS, it was really good because we were able to increase the sample size to 3,000 and extend the funding up until February 2022. And we combined forces with UMC to run MERMAIDS-ARI 2. And that was because we had that gapping funding. We lost a bit of engagement with the sites, but fortunately UMCU were also set up and were able to work through their networks to also engage in observational studies in RE. And what MERMAIDS was able to do for COVID was we were able to compare those mild and severe cases and with other respiratory viruses. We were able to stratify by comorbidity and look at the host responses and pathophysiology in COVID-19 and look at the different host mechanisms that underlie disease for severity of COVID. So that's why having MERMAIDS pre-positioned from Prepare was really important and it all came when COVID came. So, you know, it just goes to show that having these observational studies set up in time for pandemics really does work. Next slide, please. So this is how recruitment works. I see one of the boxes has gone a bit funny. So in the first season, back in 2016, we didn't recruit many patients. The usual excuses of setting up contracts, getting ethical approvals, that type of thing. But from 2016-17 onwards, we consistently recruited up until now, where we're still recruiting patients for COVID-19. So I think we've got about 2,300 patients at the moment, and we're continuing to recruit until early 2022. Next slide, please. So what's to come? So it's to come because we've got that great excuse. Because we had COVID, we were unable to do a lot of the fun scientific work and analyze all of the data in previous seasons. So like most of us here, we can blame that on COVID. So what's going to come? We've got a cohort description paper, which is coming later this year. We've got the gene expression papers being run out of Amsterdam to come later this year and in 2022. We've got the serological analyses being run out of Rotterdam, and that will hopefully be coming later this year or next year. Patricia will mention in the next talk about we're looking at those hospitalized progressor patients, so those that get hospitalized and get even more severe disease whilst they're hospitalized. And then, of course, what's important is the perpetual observational study in RE. So yeah, so this is what's to come in the future. And please keep in contact with the Ecraid website. The great communications team there, I'm sure, will disseminate all of this information through Ecraid. So please keep in touch with the Ecraid communications. Next slide, please. And I'd like to pick out the top 3 things that worked well for us and what didn't work well. There's lots of things, but these are personally my 3 as being the study manager for this. So first of all, the cross-work package collaboration. I mean, without all of the different work packages, we absolutely could not run a study as successfully as this. And I put a picture of the sample kits there that are produced out of University Antwerp. And the feedback from all of the sites and study teams say this is the best study they've ever worked on, purely because of the way that these study kits are set up. They're really clear, they're color-coded. So, hats off to the guys in Antwerp for doing this. If it was me that was designing this, it wouldn't look as good as that. So thank you very much to the Antwerp team. And obviously what worked well was we had a pre-positioned protocol, so that when the pandemic came, we were able to activate MERMAID straight away. And what always happens is that the research always starts really late, but within the first month, we recruited a patient into MERMAID. So it was a really good success there for having these observational studies set up. And the engagement with sites, I mean, that's the thing that really works well, and we need to continue doing that. So I think obviously because we had that gap in funding, we lost a bit of engagement there. But what really did work is whilst the study was operative, we were able to really engage with the sites and keep things ticking over. And I've put a little image there of research online. Again, they're another really important part of the cross-work package collaboration. They run the database, and UMC Utrecht for the reactivation of COVID, where they were able to recruit patients in the wider Europe that we weren't able to target, and that really helped as well. Next slide, please. And what didn't work well, as I've mentioned, we had the gap in funding from Prepare to Recover. And what also happened was we had poor serial sampling and case report form completeness for when we reactivated for COVID. Because we had that large burden on the sites where they were responding clinically, that did affect the research a little bit. We didn't get that consistency with the serial sampling and the completeness on the case report form. And also what hasn't worked well, and I think this is the experience for a lot of the clinical sites, is payment mechanisms and invoicing and getting it to work with the EU funding rules, and also getting it to match up to our institutional rules. This is something that's often very difficult. And I'm hopefully going to come on in the next slide to how we can improve on these 3 things. So first of all, We've got the gap in funding from Prepare to Recover, but with the ECRAID funding and model, this equals self-sustainability. So I don't think we're going to have that issue in the future. Next one. I mentioned about the poor serial sampling and completeness for case report forms. So our proposed sampling schedule for POS-ARI is just that one single time point on day 0 and a really refined case report form. So this will make it a lot less burdensome on sites. We'll still be able to answer the objectives of the study. And in an outbreak scenario, this will make things a lot easier to collect really solid scientific information. And then I mentioned about the payment mechanisms and invoicing and how it's difficult within our institutions to get things right. But with ECRAID Foundation set up, we'll have this centralized contracting and site payment system. And I think that will strengthen the relationships with all of the sites and make things a lot simpler for us in our institutions to run the study, and then also for the recruiting sites to understand how things work, because it will be consistent across all of the different clinical activities. And this is a thank you and also an apology slide, because I did start to put together lots of thank yous and I had lots of pictures, but the slides were going on and on and on because we've been working on this for so long and there's so many people involved. So just a big thank you to everybody, all of the protocol investigators, everybody from Prepare, Recover, Combat, ECRAID, obviously all of the site investigators. I mean, there's hundreds and hundreds of people to thank. So yeah, and this is one of our old Prepare photos. I wanted to put it in so you can see how much we've all aged. Yeah, and that's all from me. Any questions would be great. Thanks.
Thank you very much, James, and also thank you for your very kind words for the team in Antwerp. But what you didn't mention on your top 3, what worked well, was the fact that you need a dedicated, passionate, and very committed let's say operational manager and trial lead, and that's what you are. So that's why it's also been very successful, James. So thank you very much.
Well, thanks, Herman. Appreciate that. Cheers.
All right. Good. Is there a question for James? You can always think about your questions and ask them in the chat, of course, and then maybe James, if you could answer any questions in the chat function, that would also be great.
Sure.
I can't see any hands. Any questions? Good. So once again, thank you very much, James. And it's going to be really exciting now, because now you're going to start looking at the data, analyzing the results, and then come up with interesting papers. Huh? So it's going to be very exciting now. All right, super. Good. So then we'll move on to MERMAIDS-ARI 2.0. Patricia Bruijning-Verhagen from the University Medical Center Utrecht. Patricia.
Thank you, Herman. So good morning, everyone, and thanks again, or it's afternoon already, I see. Thanks for giving me the opportunity to present on the MERMAIDS 2.0 study. James has already explained how the MERMAID studies, where they emerged from, and how they were developed over time. Next slide, please. So MERMAIDS 2 basically starts with Recover. Recover was launched in March 2020 as a clinical research response to the COVID-19 pandemic. Within the hospital care study, there are many different elements within Recover, but one is the hospital care study. We started with the reactivation of MERMAIDS 1.0, but also developing a protocol which was slightly more tailored towards studying COVID-19 specifically, which we named MERMAIDS-ARI 2.0 protocol. Now the idea was to use the Compacting CLIN networks to recruit a large number of sites and really to focus on the initial research questions that emerged during the pandemic, focusing on the description of clinical disease spectrum and severity, risk groups, patient characteristics, etc. Next slide, please. So this is indeed what we put in the application back in March 2020. But as the epidemic evolved, it became clear that some of these research objectives were already addressed early on in the first month of the epidemic, but that more specifically, more complicated research questions that require more detailed patient data, longitudinal data, and also longitudinal biosamples were not yet addressed and also difficult to tackle because they require a different kind of research infrastructure. Next slide. And we had already put in several secondary objectives, but I think as with everything during the COVID-19 pandemic, the objectives are also a bit adaptive to the situation and the timeliness of the research questions. And the ones where I put the arrows are the ones that are most relevant at the moment, we think, and the focus really of our cohort and our planned analysis for the near future. So really focusing on pathogen replication and excretion in the host and on the host responses to infection and therapy, looking into different kind of the immune signaling molecules and gene expression profiles, but also host genetic variants. Next slide, please. As said, the MERMAIDS-2 study was more focused on studying COVID-19 rather than acute respiratory illness in general. Other slight differences were that we focused exclusively on hospital care. So it's the moderately and severe patient population. And we also included a subset of patients that were enrolled in a long-term follow-up post-discharge. Next slide. Another change we made compared to the protocol 1.0 is that we further extended the biosampling scheme. So apart from the samples taken on admission, there's another sample taken on day 7 or at day 28, depending also on the length of stay, obviously, of the patient and discharge. And we had a second tier of the sampling scheme, which then on top of the regular samples also included blood CPT, which is needed for studying immune cells, so the peripheral blood monocytes, the PBMCs. Next slide. So this is a snapshot of September 2021, and I see this number is already outdated because I heard this morning that we just recently passed the 300 enrollment number. And what you see here is an overview of the sites that participated in the study so far and the number of subjects enrolled. Next slide, please. What I would like to stress is this is a brief overview of the patient characteristics and the patient outcomes based on the export of the data early August. So not all patients are in this yet. But what you can actually see from these data, and that's I think a general feature of the MERMAID sites that are participating in MERMAIDS 2.0, is that the data completeness is quite high, and we have very few missing data. This is not even complete for all sites yet. So yeah, we're still getting more data in for these patients, for especially about the post-discharge follow-up, obviously. Next slide, please. And the same also holds true for the biosampling. One of the most challenging issues in an observational study is to obtain the different biological samples from your patient population. This is all usually these patients are hospitalized, so there are blood draws done for routine clinical care, and then on top of that, there is a couple of mLs several times during hospital stay that is required for the study. There's additional nasal or nasopharyngeal sampling. And we know from experience that it's always complicated to get your samples complete for your patients. So we're quite happy actually with what we have achieved so far in this study. Again, this is not for the complete data set yet, but well, for the large majority of patients, we have samples early on during hospital stay, so day 1, day 2, and then we have another sample day 7 or discharge, or day 28 or discharge. So these are sort of overlapping samples. So at least 2 samples for the large majority of our patients in the study set. Next slide, please. So then once you have collected these samples, the next challenge is to actually get them to the central laboratory and to do your analysis on these samples. Now, the way we set up the MERMAID studies, the shipments for the samples was done in bulk, of course. So we had regular shipments, but it does mean that the samples only arrive in the central laboratory after a couple of months, actually, and that's what you can see here. So by July 8th, we had samples for 150 patients received by the University of Antwerp. And we're still we have another round of sample collection, sample transportation planned also, but there is quite a delay between the patient discharge and the timing of arrival of the samples in the central laboratory. Next slide. So what's to come? So what we are now planning to do, as said earlier on, is we really focus on a bit more specific research questions that we can address in this extensive and detailed collection of COVID-19 patients with their biosamples. So B profiles, the T-cell responses, the intrapatient evolution of the SARS-CoV-2 virus. We also want to look into the understanding and predicting the disease progression, looking at the host gene expression profiles over time, and also look at gene sets and host-specific factors that may have an effect or that may influence responses to treatment. Next slide, please. So a few lessons learned during the setup and the conduct of the MERMAIDS-2 study. I think it has been mentioned several times already today and before, is that setting up a new multinational study during a pandemic when clinical care is really overwhelmed is very challenging. So it took us quite some time to get the study up and running in the different countries. It also meant that from the sites that were in our network, and we have a very extensive network within ClinNet, of course, but the number of sites that we initially approached, which was more than 75, and then the sites that actually were enrolled in the study and recruited patients, we went from over 75 to 11. And this was a very labor-intensive process, and most of the issues that we encountered were either sites were unresponsive or they were responsive initially, but then later on had to withdraw because they had staff issues. So that was the most important reason, was that the process that is needed to set up a study, there were simply no people around to actually do this at the time. One of the solutions is really to have a warm-based network and also master protocols that are, or master contracts that are already in place that can alleviate the workload for the clinicians that are also needed on the floor and that are now struggling to get these procedures done while also providing clinical care. The upside or the advantage of this whole process is that the sites that we ended up with, they are all highly engaged. And this means that they were very much committed to recruiting patients, but also to data completeness and sample completeness. So I think we end up with a very nice cohort of very well characterized patients within the MERMAIDS 2.0 study. And we have accomplished a very rich biobanking. And this is important because as I showed at the beginning, the objectives that were set at the start of the COVID-19 pandemic, there are new research questions that emerge over time, and the situation changes constantly, which requires that if you want to be able to do post hoc to address new research questions, then this data set and biobanking, that where you can go to these samples and select certain groups of patients that you want to study in more detail, is very important. And as I already said, there was quite some delay in the shipment of the samples. Now, it depends really on the setting that you're in and what you want to study, whether this is an issue or not. But for instance, when the Delta variant emerged in Europe and was spreading across Europe, it would have been interesting to have samples of patients to compare which variant was, whether they were getting more sick, for instance, with the Delta variant compared to Alpha, or to look specifically at breakthrough infections in vaccinated people. Now, and the setup of the study in MERMAIDS 2, the logistics around shipments, we were just not able to do this in a very expedited way. So I think for future studies, it would be good to have a sort of a second expedited transportation system run alongside the routine system, that you could use to really address emergency research questions during a pandemic. But of course, that needs also some additional funding. That's what I wanted to mention for MERMAIDS 2.0, and I'm happy to take any questions.
Yeah, thank you very much, Patricia. Indeed, a very challenging study, huh? But you're doing very well, and it's going to be also very exciting once the samples have been analyzed to look at the results. Huh? You came up with similar, let's say, conclusions and lessons learned. Huh? The role of the importance of building a warm base for clinical research, and the role of perpetual studies. Contracting, of course, it was an issue in all of the trials, and then funding. And indeed, yes, it would have been great if you had a lot more funding to transport the samples more quickly, but simply we had to bulk the samples and then transport them at regular intervals, but we couldn't do it too frequently because of the cost. But that was unfortunate.
Exactly. Yeah,
that was unfortunate, of course. Biobank is indeed an important issue, and I forgot to mention that in the ValueDX project, we actually have a deliverable, and that is to develop a business model for the biobank, and that we are currently developing with Deloitte as a consultant. And I can tell you this is not an easy business model to develop because it's expensive, and again, there's not always a lot of funding for biobanking, unfortunately. Yeah. Any questions for Patricia? One from Evelyn. Evelyn, there could be other solution to avoid the delays. Has the use of additional labs, and then I can't see the rest of the chat. Has the use of additional labs been considered, for example? I don't know what you mean exactly. Well, Patricia, you want to answer that question?
Yes, I don't know exactly what is meant with additional labs. Obviously, the hospitals that participated in MERMAIDS, they have their own labs. So yes, you could do specific analysis. You could consider doing some of the analysis locally rather than doing everything centrally. I think that's perhaps what she refers to. But yeah, maybe that would be something indeed to consider for the future. I think when we started the MERMAID study, we didn't really anticipate that we would have to be studying variants, for instance, not in the way that it evolved during the pandemic. So yeah, it's always difficult to know in which direction you need to go. But yeah, I think it could be one of the solutions apart from having perhaps just a subset of samples in specific patients that you want to study swiftly, having them transported sooner.
Yeah, but it really depends on the tests that need to be done.
Exactly.
Because Evelien, we use different models. So sometimes we use the central lab because you want to use a standardized test for all the samples, or we use national labs, reference labs, and send them to these national labs, or that everything, as Patricia says, is done locally. So it really depends on the tests in the trial. Huh? Yeah. Okay, it's really unfortunate we don't have more time for discussion, because that was the whole idea of the face-to-face meeting, and where we had to cut down the agenda of the meeting. So therefore, there's indeed little time for discussion. But again, if you have a question, please put in the chat box, and I'm sure Patricia will be able to answer your question. So many thanks again, Patricia, and also for all the hard work for doing such a difficult study. Good, and now we'll move on to honors preps. Another ECRAID-driven study will be presented by Marlieke de Kraker from the University Hospital and Medical Faculty of Geneva. Marlieke.
Hey, hi, Herman, thank you. So good afternoon, everybody. Thank you for giving me the opportunity to talk about honors preps, a study that's actually part of Completeness and a precursor of the VAP+ study within ECRAID. Next slide, please. As you all know, there are many challenges in setting up randomized clinical trials. For example, the startup of a randomized clinical trial is often very slow and very costly. So preferably, you would like to approach sites as efficiently as possible. And it would be very helpful if you would have access to actively recruiting sites with a high quality. Within randomized clinical trials, endpoints are also crucial for the planning and the possible success of the trial. Unfortunately, in many cases, FDA and EMA endpoints are not aligned, and they also do not align very well with, for example, expert opinion about important endpoints or patient-oriented outcomes. And it would be very useful if we would have data about these different endpoints to be able to plan our trial based on, for example, recruitment projections, based on these chosen endpoints. Next slide, please. In the antibacterial domain, the setup of randomized clinical trials is even more challenging. Often controls, of course, have the best available therapy, which means that there will be small differences between study arms, which means that you would need a big sample size. At the same time, if you're focusing on specific infections by specific pathogens, or you're interested in specific drug-resistant bugs, the incidence of the infections that you can recruit is often quite low. So how do you make sure that you have a large sample size for your study? Again, it would be very helpful if we would have empirical data to inform population enrichment, or to select sites with high numbers of the infections of interest. For all of these reasons, we initiated the setup of a platform study within Completeness. The specific study here is honors preps, which stands for a hospital network study, a preparation for randomized evaluation of anti-pneumonia strategies. Next slide, please. Habfab is one of the most common nosocomial infections actually in adults. And there's about 700,000 cases in the EU per year, and 27,000 associated deaths. Next slide, please. At the same time, there are numerous phase 1 trials currently ongoing, looking at novel Habfab antibiotics. And within Completeness itself, there have been 2 phase 2 preventive trials. I think Mark already explained quite a bit about these 2 studies. They were called Satellite and Evade, and they looked at monoclonal antibodies that could prevent development of Habfab. The Satellite trial looked at sufratuximab, and actually they're now, together with Aridis, planning a phase 3 trial to continue the development of this preventive treatment. At the same time, there's still discussion about the best endpoints in Habfab trials. And within StatNet, another part of the Completeness project, a partner developed novel endpoints for Habfab based on expert opinion. It's a hierarchical endpoint looking at survival, mechanical ventilation-free days and clinical cure. However, these endpoints have not yet been validated with empirical data. And of course, if you're planning a randomized clinical trial, you would need to know if you could use this endpoint, whether it would be feasible. Next slide, please. So for all of these reasons, we got the assignment within Completeness to set up a platform study looking at Habfab. The problem was that for this study, the primary objective was not very clinically oriented. Basically, we were asked to set up a network that could be a warm base for randomized clinical trials. So we've had a lot of discussions about what would be the primary objective of something of a platform like this. So in the end, we decided to focus the primary objective really on the quality and efficiency of the platform, while the secondary objectives would focus more on clinical outcomes, like the incidence, microbiological etiology, management and outcome of Habfab, and also, for example, infection prevention and control measures in the different centers and their association with the incidence of Habfab by site. Next slide, please. Since the primary objective was not very standard, the sample size was not very standard either. So I think also now within the POS studies, there's a lot of discussion of, okay, where do we base our sample size calculation on? So for us, because the primary objective really focused on quality and efficiency, our sample size calculation was focused on that as well. So it was a co-primary endpoint. First one, looking at the at-risk population for Habfab. And there we determined that the success criterion would be the proportion of screened eligible patients that were enrolled within 84 hours of ICU admission. Then that would be combined with an endpoint for the Habfab population, so for treatment trials, whereby the focus was on the proportion of enrolled patients who would develop Habfab, who were registered in the CRF within 24 hours after onset, whereby onset was defined as the X-ray finding the clinical indication. So based on that, and based on the number of sites that we expected to include in this study and the duration of the study, we estimated that we could enroll possibly 3,000 patients at risk of Habfab. And if we would then say that our target would be 75% of these patients should be enrolled within 48 hours, based on this sample size, we could detect that target with a precision of 3%. For the second part of the co-primary endpoint, we expected that we would enroll about 480 patients with Habfab based on an incidence of 16%. If we would then set our target at 90% being registered within 24 hours, we could estimate this with a precision of 4%. Next slide, please. So the network has been running for 1 year now, and at the moment we have 9 sites. Actually, we were aiming for 15, but as you all know, there was COVID, which very complicated this study a lot, especially because this study focused on the ICU, where of course we had lots of workload and very little space for other patients than COVID at certain points in time. The idea of Completeness was to recruit, sorry, could you still go back to the previous slide? Thank you. The idea of Completeness was also to focus this study on Eastern Europe, or Central Europe, some people prefer to say, because there's still a lot of hospitals there that do not participate in clinical trials. And through this study, we could actually include these sites, train them, and make them prepare them for the quality that is needed for randomized clinical trials. Since the recruitment of sites was very difficult, we said, okay, we need to change something. So we also extended now our area of interest to the whole of Europe. And as you can see, there's currently also a French site that has just started a few months ago that is also part of Honest Preps. And this will also help in if we change over into the VAPPOS study, because within VAPPOS, there's no specific criterion of focusing on a certain region in Europe. As you can see, at the moment, we have 1,311 patients included in the study. Next slide, please. So what if you would want to set up a randomized clinical trial in this domain? Well, with this platform study that we're currently running, we can actually look, for example, at the quality of the sites. we have a BI tool, a real-time BI tool, where you can see the number of forms of the ECRF that are completed. So you can see it here by site. In blue, those forms are all completed. And then you can see, for example, the site in the middle, there's quite still a lot of green forms, which means that they actually have a big backlog. So if you want to start up a randomized clinical trial, you might not select this site for your study. Another thing that you can, for example, also look at when you're interested in quality is a look at the number of open queries, for example, per site. If you look at our primary endpoints that we included for the study, at the moment, the proportion of screened eligible patients being enrolled within 48 hours is 93%. So that's actually very high, higher than our target. So we're very happy with that. But if we look at the other part of the primary endpoint, we can see that the proportion of enrolled patients with Habfab being registered within 24 hours is actually quite low. This might look very disappointing, but actually there's a few clear reasons why this proportion was quite low. One of them was that we had some problems with the IT tool that we used for the ECRF, which meant that the Habfab forms were not created within the platform. And that's why sites couldn't enter the patients as quickly as they wanted to. There's also, of course, always site-specific problems. For example, one site changed their system, their hospital information system, so they couldn't access information from patients for a while. And of course, COVID played a very big role in this as well. Next slide, please. So what if you would want to do a randomized clinical trial looking at patients at risk of Habfab? What kind of recruitment rates can you expect? So again, we can just take the information from our study to inform interested parties about our recruitment rates. Of course, here you can see sites started at different points in time. Some sites started very quickly, but slowed down. Some sites started a bit slower, but then sped up. And you can see that if you would start a study now, there's a very high recruitment rate compared to if you would start as a randomized clinical trial at day 0, where you would still need to include all of the sites, and your recruitment duration will be a lot longer for your study. Next slide, please. What if you are not interested in preventive treatments, but you're interested in treating Habfab in your randomized clinical trial? What can you expect? So again, the data within the trial, within our platform, shows you that we have an incidence of 16% of Habfab among all included patients. And you can see there's a huge variation between sites. So of course you could select sites where this incidence is a lot higher to be able to include a lot more patients. At the same time, you can of course also inform interested parties about the clinical outcomes, like for example here, all-cause mortality, which might seem a bit low here because it's 10%, but it's because some of the patients haven't reached their endpoints yet. Next slide, please. So all of this information is really nice based on the data that we've collected. But of course, you can take it even a step further and use simulations to look using recruitment rates and study durations to inform interested parties about what are the possibilities. And then you could, of course, also add adaptive designs. So, for example, you could include group sequential designs to reduce the study duration. You could do sample size re-estimations to maintain power within your study. Or you could do multi-arm, multi-stage designs to increase efficiency. So just a small example that within StatNet we've been working on. So say you want to do a future phase 3 trial focused on a novel compound to prevent Habfab in the ICU. So almost something like Aridis. So we used, at the moment we use the data from Aspire ICU because the data from Honest Preps is still, we're still collecting and we want to wait for a bit more data, but we could do exactly the same thing. And what if we would apply a group sequential design whereby you could do interim looks at the data and possibly terminate your study early? Next slide, please. So here are the key parameters that we could use from the Aspire ICU data to inform site recruitment and the impact of group sequential design. So on the left side, you can see recruitment rates. And basically, we divided the period into two. So the startup phase and the ongoing recruitment. And in the first phase, there was only a recruitment of 18 patients per month. And actually in the second phase, there was a recruitment of 76 patients per month. So you can already see that there's a huge gain if you can use a warm base for your randomized clinical trial. On the right side, you can see the cumulative incidence of VAP patients with an overall incidence of 16% at day 28. Next slide, please. So then based on this data, what if we would assume that there's a treatment effect of 30% reduction in VAP incidence? What number of events would we need, and what would the recruitment look like, and how long would the study duration be? So with this number of events, we would need about 500 patients, so that's at the end of the graph. If we look at the blue line, that would be the recruitment based on Aspire ICU from day 0. And then you can see your study duration would be about 16 months. And then that's the dash. So the dashed line is patient recruitment. The blue line is end of the study, because of course you need to follow up patients until their endpoint. However, if we use Aspire ICU as a warm base, and we start at a later stage in this recruitment procedure from Aspire ICU, we would have the brown line down there for the recruitment. And if we would then need 500 patients, the study duration would actually only be about 7 months. So that would be, the study duration would be halved by using a warm base compared to starting up an RCT without a warm base. Next slide, please. So what if we would implement a group sequential design where we would do 2 interim analyses at 50% and 75% plus a final analysis? Again, we would assume a sample size of about 500 patients and an impact of 30% reduction. So the top graph, I can see that the axis disappeared, but it's the hazard ratio at the bottom on the x-axis. So if we assume a 30% reduction, that's a hazard ratio of 0.68. And then we can see, if you look at the red line, that there would be a 54% chance of stopping at interim 1 or 2. And actually, that would mean that we would need about 180 versus 250 events. So that will be quite a big reduction. And if you then look at the bottom graph, you can see that the first analysis would be at about 5 months, and the second analysis would be about at 6 months. I'm sorry, just checking the chat. Yes. I'm getting there. So then again, if you would do this group sequential design, you could actually save 1 to 2 months of your study duration based on the Aspire ICU data. So these kind of simulations can really inform interested parties about what are the options with this kind of data in this warm-based network. Next slide, please. So the conclusions. So as you can see, data from platform studies are very valuable for site selection, also for population enrichment. I didn't really show that, but of course we have a lot of clinical data as well, and also for validation of novel endpoints. The data from the platform is also valuable for simulations, and that can help to give an indication of trial duration and the feasibility or added value of adaptive trial designs. A short bit on lessons learned as well. So the training of sites with little experience takes a lot of time. And then unexpected events can really heavily influence success. So of course, COVID-19, as said before, the huge workload of clinical centers, but also the signing of informed consent forms, because often family was not available on the ICU because of limited visitors. So there was a huge problem actually to get informed consent forms signed. Like I mentioned before, changes in hospital information systems, IT problems can all really influence the success of your network. Next slide, please. So what are our next steps?
Marlieke, I think you need to conclude now, huh?
Yeah, this is the last slide. So in fall, LabNet will still start its training within the honors prep study sites, a training on sampling and screening, and also the detection of Habfab pathogens. We're still recruiting sites, but that will stop at the end of October, and patient recruitment will end May 2022. We're preparing a manuscript about the feasibility of adaptive designs. We're preparing a report for IMI, and we're currently contributing to VAPPAS, to the protocol and ECRF development, and making sure that sites can also transfer to the VAPOS study. Thank you.
Okay, thank you very much, Marlieke. And unfortunately, we don't have any time for discussion here, but thank you for sharing this interesting data. And I should have mentioned that this is also where StatNet is based, and that's why you also develop all these scenarios for Habfab trials. So thank you again, Marlieke, and also thank you for investing a lot in the Balkan region and for training these sites to participate in the clinical trials, because that's an important region to do clinical studies, particularly on antimicrobial resistance. All right. Good. So then we'll move on to one of the most successful trials, I think, in Europe, and not only Europe, but also globally. And that is, of course, thanks to the fantastic support and hard work of Lennie Derde. So, Lennie, you have the floor.
Thanks, Herman. So thanks for allowing me to talk to you all about REMAP-CAP. And as you know, this is not a COVID-19 project. This project was started under PREPARE funding. PREPARE funding was actually the seed funding for the global trial, which made it possible for us to acquire other grants. So the European Commission has been instrumental in the success of REMAP-CAP. And to inform you about why we set it up the way we did, I'd like to take you back to the beginning of this pandemic. Next slide. So this is what my life was like in March 2020. I work in an ICU in Utrecht in the Netherlands. We usually have 24 beds open, but in the first surge, we had 80 beds open. We had 3 different locations. And can I have the next slide? We were working with people that we didn't know, so that we actually had to put stickers on our head with our first names to be able to recognize each other. And what's especially evident from this picture to me is the kind of mild anxiety in the eyes of one of my colleagues, and the fact that each of the clocks says that's it, it's 11:45. So that's kind of the feeling that clinicians had in the first surge of COVID. And all they could think was, and I thought this myself, was just, give us a drug to treat these patients. Let us help these patients. We want to do something now. Can I have the next slide? But there was also another sentiment in me. And that was, we need to find out what the best treatment is. And I think nobody said it better than Jeremy Farrar, the director of the Wellcome Trust, who said, the only way out of this pandemic is science. Can I have the next slide? And this is a very interesting thing, because this is how it's usually visualized or conferred, is that you either do something, you treat the patient, or you investigate something. You investigate which drug is the best or what the effect of the drug is. And that's kind of reality. But if you think about it, it's probably not the best way to solve it. The best way is probably to kind of merge these boxing gloves and fight the common enemy, to do some kind of blended approach, not just learning, not just doing, but learning while you do. Can I have the next slide? But the interesting thing is that medicine isn't organized that way. It's organized into pillars. We organize research separately from clinical practice. There's all kinds of reasons for that. We have different institutions, different protocols, different structures, and there may be good reasons for that. But especially during the pandemic, it became evident that there's also a cost to organizing medicine in this way. Can I have the next slide? And let me take you through some of the challenges that doing clinical research during a pandemic can have related to this way that medicine is organized. So firstly, randomization can be uncomfortable because, as I just showed you, for clinicians, it's really, really stressful to not have a drug to treat their patient, and kind of the will to give something that is available, even if the evidence of its effectiveness is limited, is just very high. And kind of the drawbacks of not learning are more abstract, more longer term. So they're not that, in front of everybody's mind. So randomization can be uncomfortable. The second issue is that randomized control trials are cumbersome. So Marlieke just alluded to this. They can take lots of time and money to set up. Everybody who's done a randomized control trials knows that. And even if the trial is live, it's much more quick for a clinician to prescribe ivermectin than to randomize a patient into a trial on ivermectin for COVID-19, just to give an example. And the last challenge to learning in a pandemic, is what Herman has called academic cannibalism. So the research community doesn't come up with a unified plan of what is important to investigate. People have differing opinions, different research groups kind of compete for hospitals to recruit their patients. We all compete for grants. We don't have a unified plan. Can I have the next slide? And what I'm going to try and do is show you how REMAP-CAP has tried to address these challenges of learning and combining learning while doing. So if you would do a randomized controlled trial and you would have 3 things that you think are very important to investigate, and you would do them in series, you have to set up the trial 3 times. You have to, get the sites, do the CRF, collect the data, analyze them, publish it, find new funding for the next trial. So this is a very cumbersome strategy. Can I have the next slide? So what REMAP-CAP has done, as an example of an adaptive platform trial, is we flip the thinking and we think from the disease rather than from the intervention. So if you can include COVID-19 patients in a variety of randomized controlled trials, so to say, at the same time, that's much more efficient. And we call all these kind of sub-trials or modules, we call them domains in REMAP-CAP. If you push the forward button one more time, Joost. So we call them domains. So what we do is we randomize patients from multiple domains, multiple trials under the same umbrella at the same time, and we randomize them for one intervention only for each of these domains, and they end up with a whole randomized treatment regimen. And there's all kinds of advantages to that. Can I have the next slide? Move them forward about 4 times until we have a complete slide. So the other thing that makes randomization more comfortable in adaptive platform trials like REMAP-CAP is that we drop inferior interventions quickly. So what we do is we pre-specify when we think something is a success, superiority, or when something fails, inferiority. And we, by the design of the trial, can have multiple looks under the hood of the trial, and we can see when an intervention, for instance, is inferior, as you can see in the left lower panel on this slide. And then as soon as that happens, the intervention is dropped and the trial just continues. Can I have the next slide? So that's another advantage of trials like REMAP-CAP. The other advantage of platform trials is they are a one-stop shop. So we don't have to extensively discuss which single intervention is the most important to do a trial about first, because we can investigate multiple aspects of the treatment at the same time. So using a platform is much more efficient. Can I have the next slide? Another thing that we've tried to do, and we think is important for learning in a pandemic, is to realize that perfect is the enemy of the good. So if you want to build the perfect cathedral, it's going to take you a long time. And during a pandemic, you need answers quickly. And it may be very reasonable to drop something like a placebo control for the sake of getting important answers. And this is not just REMAP-CAP, but many of the trials, platform trials that have contributed in the pandemic have done things like this. Can I have the next slide? And the last important thing, if you want to learn in a pandemic, is you have to cast a big net. That's okay, Joost. So that's why we roll out REMAP-CAP, not just in Europe, but across the globe. Can I have the next slide? So in the next couple of minutes, I'm going to try and convince you that the pudding is really the pudding. So the proof of the pudding is in the eating. So has REMAP-CAP delivered what it was always intended to do by design? Can I have the next slide? And I'll go through them very quickly. Okay, so this is how we started: seed funding from Prepare. Collaborators in Canada, Australia, New Zealand. Can I have the next one? And this is the current network that has expanded in the last year and a half majorly. Can I have the next slide? We've also expanded the number of people working on the trial, because from these superheroes that were present since the start of Prepare and REMAP-CAP, we have now moved to a much bigger team. On the next slide. That's about 20 FTE in the UMCU alone. Can I have the next one, Joost? Oh, all right. So yes, this one. So this is not even complete anymore. New faces have come along, but these people are doing a lot of work, and that's shown on the timeline in the next slide. where you can see the number of domains, so the number of modules that we've added in the last year and a half. And I just want to stress, the incredible amount of work done by the team at the UMCU. They've initiated more than 70 sites single-handedly in a year and a half, which is a huge amount of work. They've helped start up 140 sites in the UK, where we have great collaborators who've done much of the work. They've done over 200 substantial amendments in 15 countries with all the paperwork and the translations that come with that. They've done contracts for over 200 sites. They've organized monitoring, medication, handled safety issues, and now we're in a space where we are doing a lot of audits and inspections because we're a high-profile trial. Can I have the next one? So this is a recruitment graph where you can see the kind of the speed we were at the beginning of the pandemic, and that's then translated into the red dotted line. And you can see that in the first wave, we were able to kind of follow the pandemic, but we especially recruited fast in the second wave. And we now continue to recruit because the pandemic is still active and we've expanded our network. So we are going where the pandemic is. Next slide. So these are the numbers. We've recruited almost 9,000 patients, translating to over 16,000 randomizations in hospitalized patients, including COVID and non-COVID. Can I have the next one? And then, okay, let's go over these for the sake of time, because I don't want us to be late for lunch. So Joost, if you go through to the overview slide with the dotted circles, then I'll just tell you that we have had 10 platform conclusions in 18 months, of which obviously the fact that corticosteroids and IL-6 receptor antagonists, stop here, were effective was absolutely great. We recently published the data on therapeutic anticoagulation in ward patients, which was effective. So that was published in August. And we've also been able to quickly eliminate some things that we thought were effective, but we proved were not effective. Although, for instance, for convalescent plasma, there may still be subgroups that benefit. Can I have the next one? So there are still a lot of things we are investigating for COVID, but also for regular CAP. And we hope to continue to do that. And that's also one of the advantages of a platform trial. Can I have the next one? We're also focusing on disseminating these results, which is very important, through all kinds of methods. And as a closing slide, I'd just like to say that I'm the person speaking here, but the work has really been done by a huge number of people in the EU and also outside the EU that we refer to as the REMAP-CAP family. So with that, thank you. And Herman, the floor is back to you.
Thank you very much, Lennie. You know, Lennie, you were talking about superheroes, but as you know very well, you are my hero. Huh? There's nobody who can explain better than you what the complex mechanism of a platform trial. And I always love your talks because you always have new, nice visuals. It's really fantastic. It's a joy to listen to your talks, Lennie. Honestly, it is. So wonderful.
Thanks,
and great job. We're very proud of you, Lennie. Honestly, we are. Good. We don't have much time, but there is one question I think we could, maybe you could take that one, Lennie. So it's from James. And he's asking, do you think it's going to be possible to continue with the recruitment momentum post-COVID, Lennie?
Yeah, it's a very important question, James, because that's why I stressed at the beginning that this is not just a COVID trial. So we started out investigating the best treatment for CAP, and CAP is not just COVID. So we are setting up new interventions for like influenza and other causes of CAP. And while we think that, there will likely be sites dropping their interest after the COVID pandemic, we also see that the fact that we've now kind of proven that kind of the system works is also gaining a lot of enthusiasm in other sites. So I don't know where we'll end up, but we'll do our best to keep our sites engaged and find more answers for the best treatment of CAP.
Super. All right, Lennie. Thanks again. Huh? Good. So we will finish then with our new kid in town, ECRAID-PRIME, and Marlieke van der Velde will tell you all about ECRAID-PRIME. Marlieke?
Yeah, thank you very much, Herman. ECRAID-PRIME is the new kid in town. I'm the old one in town, but happy to present this new kid on the block. So thank you inviting me and Chris to present ECRAID-PRIME today. And PRIME was recently awarded funding by the EU in Horizon Europe. Next slide, please. How did it all start? It was just when COVID-related workload was decreasing that we received a phone call from Herman. EU funding was available for early phase research on treatments for COVID-19 patients in the community. We had 2 weeks available to write a grant proposal, but with the reassurance that Frank Dege was available to coordinate and support. 2 very hectic weeks, but who dares to say no to such an opportunity and request from Herman? And when finished, we appear to have a few extra days due to a cyber attack on the EU portal for some fine-tuning. But very early on Mother's Day, Sunday morning, Herman rang with a clear message. No fine-tuning, but fully rewrite the proposal to link it to ECRAID. And then the pieces of the puzzle fell together, resulting in a strong, coherent proposal building on the vision and infrastructure of ECRAID. And ECRAID-PRIME was born, European Clinical Research Alliance on Infectious Diseases, a primary care adaptive platform trial for pandemics and epidemics. Next slide, please. The drivers behind ECRAID-PRIME. So from the start of the pandemic, there have been highly successful international platform trials for therapeutics for patients admitted to hospital and ICU. REMAP-CAP, we just heard an EU response with a presentation this afternoon. The majority of patients with COVID-19, however, are managed in the community by general practitioners. There are promising treatments, newly developed or new combinations for early treatment of COVID-19 with the aim to speed recovery and reduce complications like hospitalization and long COVID. And these need early phase evaluation in the primary care setting. Next slide. The successes of the large international platform trials in secondary care stressed the inefficiency of setting up a new trial for each intervention that comes along. And platform trials prevent successive underpowered studies. And rapid large-scale evaluation of treatments in the community will remain needed for future epidemic and pandemic threats. So therefore, we proposed a multi-country adaptive platform trial in primary care. So in short, an adaptive platform trial is a perpetual study governed by a master protocol and allows the evaluation of several treatments simultaneously and in series. And by using advanced statistical methods, treatments can be dropped quickly for safety reasons or futility, and new arms can be added, making optimal use of a shared placebo group and of research resources. Next slide. So the overall goal of ECRAID-PRIME is to efficiently and rigorously evaluate candidate therapeutic agents for community treatment of COVID-19 in an early phase international study with a platform trial architecture. An international coordinated approach is needed to be responsive to variation in incidence and to the emergence of new variant strains. And focus will be on phase 2, evaluating the safety and efficacy of agents and the suitability for progression into a phase 3 evaluation. Phase 3 evaluation is outside the scope of ECRAID-PRIME and can be done, for example, in principle. A well-developed phase 3 platform trial capability evaluating community treatments for COVID, recruiting in the UK and led by Chris. The specific objectives for ECRAID-PRIME are first to develop a master protocol and submit for regulatory approval in up to 6 European countries, implement a transparent mechanism for selecting suitable agents with a maximal chance of benefiting COVID patients in primary care, develop intervention-specific appendices to the master protocol for at least 3 therapeutic agents and to complete their evaluation, and conduct a qualitative sub-study to explore patient, clinician, and trial personnel's experiences of taking part in and delivering a platform trial. Next slide. We have 4 partners in ECRAID-PRIME: University Medical Center Utrecht, University of Oxford, University of Antwerp, and Ecraid in France. And the overall organization of PRIME and the work package structure is very similar to that of Ecraid-base. So PRIME will make optimal use of the structures being built in Ecraid-base. Next slide. And to make it a bit more personal, these are the work package leads and co-leads preparing for the start of Ecraid-PRIME, as PRIME is now in its grant agreement preparation phase. So Chris and I will lead the consortium, and at UMCU we have Mark, Ram, Frank Leus, and Roderick Venekamp involved, and in Antwerp, Herman and Soerbi, Jacques de Mot at Ecraid and John Arno Rottinge as member of the JAM for agent selection. And the next slide. So normally we end with such a slide, but it shows that more colleagues are involved already, and I expect this list to grow rapidly in the coming weeks already. And the next slide. Our primary care research network is in development and expanding from 2006 onwards through many EU-funded projects and delivered the ALICE trial in 2018. It now comprises 20 countries and is active in ValueDX. And in every country, we have one or more coordinating teams organizing the studies and managing their sites, which are primary care practices. And for the early phase research we need to do in PRIME, we aim to recruit patients via our national primary care networks and testing facilities, and refer those to a nearby hospital or specialized research facility where they can be included. And to that aim, we will be building on Ecraid's infrastructures, so the hospital and lab networks and the training and communication work packages. The next one. The common primary endpoint for each agent that will be evaluated will be a measure or a surrogate measure of efficacy, which can be, and we're still in discussion what the best choice is, symptom severities in time, time to return to usual daily activities, or time to full recovery. And furthermore, safety will be evaluated in all patients. Specific outcomes can be added per agent. So for example, antibody or cytokine titers, viral load or clearance, and additional safety parameters. Next slide. The selection of agents for PRIME will be done by an independent advisory committee that will act at the interplay of the Trial Coordination Board and the JAM, the Joint Access Advisory Mechanism. The JAM was established by the TCB as an instrument for coordinated access to REMAP-CAP, the EU response trials, and now to Ecraid-PRIME as well. And the next slide. For Ecraid-PRIME, John Arno Rottinge has been added to the JAM specifically for agents suitable for primary care. And for suitability in PRIME, agents should preferably have phase 1 or 2A data available, need to be suitable for use in primary care, so oral or intranasal administration routes, availability and cost of the agent and availability of placebo will be taken into account, and then prioritize those with expected impact on symptom duration, severity, and/or complications. JAM 2.0 now has several agents under evaluation for PRIME. An agent to stimulate the microbiome, a combination of an antiviral and an anti-inflammatory agent, an FXR inhibitor, and double-stranded RNA. Next slide. We expect Ecraid-PRIME to have a broader and longer-term impact. It is expected to further strengthen Europe's clinical research preparedness and response capacity to infectious disease outbreaks in the primary care setting, and further professionalizing the primary care network, meeting the operates requirements, nicely explained this morning by Herman. The last slide. So summarizing, our steps for the coming month are finalizing the grant agreement preparation, selecting the first agent for evaluation, select the best qualified national coordinating teams to participate in Ecraid-PRIME, and develop the master protocol. And the longer-term goals are to implement an early phase adaptive platform trial, testing at least 3 agents for suitability to progress to a phase 3 evaluation, and to further develop our network to the primary care network, research network in Europe and beyond. Well, thank you, and Chris and I are willing to take your questions, suggestions, or you can email us, whatever you like.
Super. Thank you very much, Marlieke. That was a very nice and clear presentation on a very exciting project. Huh? Yeah, really, really great. And yes, I remember how happy we were when the website of the European Commission was done. We've never been so happy about this before, but it allowed us to improve the proposal. So that was a good time.
Yeah, I think you found someone to help you with that. Or...
No.
Okay.
Nothing to do with it.
No, it was really welcome, and it really helped us.
Yeah. And by the way, I see that there are many colleagues from the European Commission present here today. So many thanks for the opportunity and for funding, at least hopefully funding, because the contract isn't signed yet. But yeah, we don't expect any problems. So thank you, colleagues from the European Commission, for your support to ECRAID-PRIME. I don't think we have. Is there a question in the chat? I see something. Somebody who thanks us for a very nice meeting, and they would like to have the presentations. Yes, indeed, the presentations will be available after this meeting. So thank you very much, Marlieke. And I suggest that we close for the lunch break. I just want to say that we have a lunch break from 1 till 2, but we would like to invite you to join us a bit earlier at 20 to 2. And while you eat your sandwich or anything else, you can watch the nice videos on the ECRAID pillars, CleanNet, LabNet, EpiNet, and StatNet. And actually, the slides will be provided afterwards. They will also be available on the website. And in the slide, there will be a link. And if you click on that link, you will also have the opportunity to look at those videos. So thank you very much for listening this morning. Enjoy your lunch, and hope to see you back at either 20 to 2 or the latest at 2 o'clock. Thank you.
Thank you. Bye.